Let's just go back and discuss what pneumonia is, some other stuff that you need to know before going into what a silhouette sign is. Right. So again, definitions. Pneumonia is just inflammation of the alveoli that's mostly caused by an infection. Lobar pneumonia is just pneumonia, but it's usually involving a large part of a lobe. Lung consolidation. Again, that is a very tricky term that I've heard people use multiple times. And I was of the impression that consolidation is just the same as pneumonia, and it's often used that way. It's often used synonymously, but unfortunately, that's not very correct. Consolidation refers not only to infection, but it refers to any pathological process that fills the alveoli with either pus or blood, fluids, or cells. So any pathology that fills the lung and alveoli with these substances is called as consolidation. It's just not infection alone. So it's right to say that pneumonia can cause lung consolidation, but not all lung consolidation is caused by pneumonia. There are other causes like pulmonary hemorrhage, pulmonary edema, fluid aspiration, etc. Next is about bronchopneumonia. Bronchopneumonia is just bronchitis plus pneumonia. Bronchitis is the inflammation of the lining of the bronchus, plus pneumonia is called bronchopneumonia. This is just a pictorial representation of what lobar pneumonia is and what bronchopneumonia is. So in A, you can see the alveoli filled with pus, and that's what we refer to as lobar pneumonia involving the right upper lobe. B and C represents normal lung. Again, in D, you can see some tiny opacities, and you can see that the bronchioles, the terminal bronchioles, are inflamed. You can see some pus in the alveoli. So bronchitis plus pneumonia is what we call bronchopneumonia. And you should remember that the bronchial inflammation predominates here rather than the alveolar inflammation. Moving on to a few chest X-ray features of lobar versus bronchopneumonia. So the chest X-ray appearances of a lobar pneumonia are quite obvious, actually. Let's go into discuss what those shadows look like. It's usually homogeneous, which involves most part of a lobe, or it could be non-segmental, where it is patchy, but it's confined to a particular lobe. You could see air bronchograms, pleural effusion, swelling of the affected lobe, even cavitation. The most common culprits for lobar pneumonia are Streptococcus pneumonia and Klebsiella pneumonia. So just keep those in mind. And it's relatively easy to identify lobar pneumonia. In case of bronchopneumonia, it's a little bit challenging to identify these on chest X-rays, especially in the early stages, when the inflammation is mainly affecting the bronchi and the bronchioles. It would only show some peribronchial thickening, which causes some small nodules in the chest X-ray. As time progresses, these nodules will start to enlarge and merge together. Occasionally, you can see pleural effusions and even moderate volume loss in the affected lobe. That's mainly due to mucus plugging and inflammatory narrowing of the bronchi, which causes collapse of that lobe, leading to some volume loss. The likely organisms that cause bronchopneumonia include Klebsiella pneumonia, E. coli, Pseudomonas, staph, strep, and a lot of anaerobes. So, like I said, it's sometimes difficult to distinguish to identify bronchopneumonia, to be honest. So making a precise distinction between a lobar pneumonia and a bronchopneumonia on the chest X-ray will sometimes be difficult. And in those hard times, you just define these ill-defined shadows just as pneumonia because we're finding it difficult to describe it. Right. So in the context of lobar pneumonia, we need to know what the lobar anatomy of a normal chest X-ray looks like. So this is just an illustration to demonstrate the same. So if you look at the figures, it's very clearly you can see that on the right side, you have the right upper lobe, you've got the right middle lobe, right lower lobe, the purple is the right lower lobe. The diaphragm is mostly formed by the right lower lobe. Similarly, on the left side, you can see the left upper lobe and the left lower lobe. So this anatomy is going to come in handy when you start identifying the location of the pneumonia. We need to identify which lobe the pneumonia is located in. The next one, you can see the lateral view, the right upper lobe, middle lobe, and the lower lobe. Again, the upper lobe and the left lower lobe. So that you need to look, I mean, you can see that the lower lobe occupies most of the diaphragmatic border. So any involvement of the diaphragmatic border usually signifies that there is some pathology in the adjacent lower lobe. As promised, we're coming back to the silhouette sign. It's the last few slides, so just to be alert, I think silhouette sign is one of the most important signs that you need to look for on a chest X-ray. So normally, so this is a normal chest X-ray that you can see. The cardiac borders and the diaphragmatic borders are usually very crisp, very sharp. And that's because the air in the lungs contrasts with the water density of the heart and the diaphragm. And therefore, if the lung air is being replaced by pus, the immediate adjacent border will become ill-defined or will start to disappear. So this chest X-ray appearance of a blurred or a missing interface is what we refer to as the silhouette sign. So any lesion that touches the border of the heart or the diaphragm or the aorta will obliterate that border, and that's the sign that we use to identify any pathologies of the adjacent lobes. So it's got a few applications. Mainly, it helps to deduce the precise position of the abnormality. So, like I said, it's important to always look for the silhouette sign. That's because sometimes that might be the only abnormality, the only abnormal feature on the chest X-ray. So it's important to look for it. On the left side, there are four pictures. These are 4 patients who are presenting with cough and fever. This is just to show you the application of the sign. So you can see that the left dome of the diaphragm is a little bit blurred, which means that there's a left lower lobe involvement. Similarly, the left cardiac border being involved shows that there's a left upper lobe involvement. So you need to correlate this with the lobe anatomy that I showed you earlier. And that's how I'm able to say which lobe is being involved. Similarly, the right cardiac border, again, signifies the right middle lobe is being involved. And then here you've got the right dome of the diaphragm, which is obscured, which shows that it could be something related to the right lower lobe. So we've got a few X-rays here. The first one is actually both of them presented to the ED with cough and fever. Like you can see on the first one, there's a shadow in the right middle zone that you can see. You can also see that the right heart border seems to be effaced. And that's the clue. Excuse me. That's a clue to a pneumonia involving the right middle lobe. Excuse me. Sorry about that. So on the second one, so the first one is about a pneumonia involving the right middle lobe. On the second one, you can see that the left dome of the diaphragm is a bit ill-defined, which means that there is a pneumonia that's involving the left lower lobe. Again, this is a diagram just to show you a few examples of X-rays. I would love to hear from you guys about what you think about each X-ray. Would somebody be able to tell me what the first one, what A shows? You could drop a message on the chat box. I just want to know how much you've understood after all I've explained to you. Excuse me. Right. So the first one is about, so if you check, it's about looking at all the borders. So it's about looking at the diaphragmatic borders and the cardiac borders. As you can see, the right cardiac border seems to be a bit effaced here. So this would represent a right middle lobe pneumonia. Similarly, the second one, there's effacement of the left cardiac border. So there is an involvement of the left upper lobe in this case. If you look at C, the left dome of the diaphragm appears to be ill-defined, and therefore that shows that there's some involvement of the left lower lobe. Similarly, you've got the right dome of the diaphragm being obscured, which shows an involvement of the right lower lobe. Excuse me. Moving on, we've got another application for the silhouette sign as well. So it can also be used for any water density lesion that is in contact with the mediastinum or the diaphragm. Like you can see here, the right dome of the diaphragm appears to be well defined, but the right cardiac border seems to be a bit effaced. So here, this was a pericardial cyst, which sort of obscured the right heart border. I think the last bit of my slide is about follow-up X-rays for pneumonia. You always need to remember that never repeat the chest X-ray before the 6-week time interval. So if you're worried about an underlying carcinoma, just do a chest X-ray at the 6-week interval. So if the chest X-ray is not clear at the 6 weeks interval, then if the patient is well and there are no worrying features, you need to keep obtaining X-rays at 4 weekly intervals to make sure that the chest X-ray is improving. But in people who are chronic smokers, who are elderly, who've got risk factors for cancer, you need to arrange an urgent bronchoscopy or a CT scan. Now, silhouette sign is a very beautiful sign. Like I said, it has got important applications, but it has got a few pitfalls. One among that is a mediastinal fat pad. So some middle-aged people will accumulate a large collection of fat adjacent to the heart, which will make the heart borders to appear ill-defined. So in fact, this patient here, he's got a fat pad on the right side, which is obscuring the right heart border. So the only way to distinguish that from lung consolidation is to remember that the fat pad is of a lower density as compared to the water density of a lung consolidation. Similarly, in patients who've got a depressed sternum, you can see that the depression of the sternum will sort of push the contents of the mediastinum laterally, which might seem like the hard borders might seem a bit ill-defined in that case. So that's another thing to keep in mind, especially in people that you know who've got a depressed sternum. So those are the two pitfalls to remember. Right. I think that's the end of the PowerPoint session. I think I've covered the basics of chest X-ray and a one clinical problem from the 10. Apologies for the coughing fits in between. I think that's about it, actually. I think it's time for the Q&A session. If anybody has any questions to ask me, I would also love Dr. Clyde to come in and join for the question-answer session, if that's okay.
Thank you, Betsy.
We can take questions.
Thank you for that wonderful talk, Betsy. I would welcome Dr. Clyde now to join us for the Q&A session. And all the participants, you can post your questions in the chat box if possible. I know some of you are finding it difficult because some of you have joined using a different email ID from your St. John's email ID. That's why chat box is not accessible for some of you. If that's the case, you can post your questions in the Johnite Academics group, and we will take it up. If not, if you want, you can just raise your hand, and then I will give you turns for asking questions. Also, Clyde, do you want to add on anything that Betsy covered upon?
No, I think that was a very concise, very crisp presentation. Good job, Betsy. And I think after all that coughing, you need a chest X-ray.
Thank you.
I think we just proceed with questions as they come. And Betsy can try fending them off first. And if there are doubts that persist, I'll step it if needed.
Sure, thanks, Clyde. I would also like to remind everyone about the feedback form. You can find the feedback form in the menu. So on top of your screen, you would be able to see a forms icon, fill chest X-ray, it's written, something like that. So you can fill in those feedback forms. We would also be posting the feedback form in the chat box soon. And for the rest of you all who are not able to gain access into the chat box, we will put the feedback form link into the Johnite Academics group as well. Anyone, any further questions? If you want to add on anything, or if you want to say your impression on the session, if you want to tell us something, just unmute yourself, and then you can share your thoughts. It's very informal session. So we are your seniors, and we have been with you all in the campus. So we know how it is to be there in the Bond Center all alone, and we've been there. So I just don't want this to be anything very formal and something that would put you away from asking us questions or criticizing us, whatever it is. Just feel free, just like how we chat across in the campus. You can just unmute yourself and then ask us, like tell us, suggest whatever you want. We would love to hear from you guys. Otherwise, it would look very unilateral. That's why. So regarding the recordings, we have recorded the session. We will try and upload it into various social media platforms. We are still working on it with the Alumni Association. Mostly, it will be uploaded in the Alumni Association YouTube channel. Stay tuned to the channel. If you have not subscribed to their channel, you can subscribe to the Alumni Association YouTube channel. For those of you who have joined the session and were not able to be with us throughout the session because of your clinical pressures or anything, I think this recording will be available there in the chat box. So you'll be able to go through it at whatever time you are free. Anything else that you guys want to add on? Yeah, thank you, Glenn. Thank you for that point. We will definitely try and include some pediatric X-rays in the next session. So the next session is planned for 30th. Not sure, 30th or 31st. When is it?
It's on the 31st.
All right. I'll see whether we can try and add some pediatric X-rays also into that. We'll work on that. Very good suggestion, Glenn. Thank you. Anything more? Looks like that is it. All right. Thank you, Fox, for coming in great numbers. We had 60 plus attendees today. Thank you all for supporting us and coming in for this. We will keep this program running year by year, for every batches. It's going. We want it to keep going just like that. So, yeah, see you for the next session, and thank you to everyone who joined us today. Thank you, Betsy. Thank you, Dr. Clyde. We will hear more from you in the next session. Thank you.
Yep. Thank you, Alex. Thank you, Betsy.
Thank you, everyone. Bye-bye.
Thanks, everyone.